Hello, everyone. Thanks for joining us for this Part B Obstetrics, Gynecology, Common Rejections and Denials webinar. My name is Mary Muko. I am a specialist on the Provider Outreach and Education team at WPS Health Solutions, and I will be your host today. Assisting me is my friend and colleague, Leanne Foster. Just as a reminder, this webinar today is designed for those who submit claims on the CMS 1500 claim form or the 837P electronic version. We include this disclaimer in all our education, and we do so to remind learners that although we made every effort to provide current information that is correct, the information is subject to change. It is on the CMS website where you will find the Medicare rules that determine final coverage. These laws, regulations, and rulings will always prevail. We will provide responses to any questions based on the facts given. And finally, just a reminder that CMS does prohibit recording of this presentation for profit-making purposes. We will record this webinar and post it as an encore presentation. You can stay informed about new postings of the latest encore presentations and other education events by reading the education e-news that we post each week on Wednesday. Here is our agenda for today. If you read the advertisement and description for this webinar, you will see, or you should have read, that during this next 60 minutes, I'm going to define rejections and denials. I'm also going to reveal reasons for common rejections and denials based on data that I have analyzed. I'm going to discuss how to fix and avoid these specific common rejections and denials that I'll be talking about today, and I'm going to provide you with many resources. You might have noticed if you looked at the electronic version of your presentation materials that there are embedded links throughout. So a lot of these great resources that I'm going to talk about today, you have access to them already. Finally, if there's time, we will answer questions that you place into the chat. Leanne is monitoring that, as I mentioned. If we don't get to questions during the live event, please don't worry. I will make certain to answer all of the presentation related questions following the event. I'll compile a list of questions and the answers and share them to all learners, or I will individually email the learner a response to his or her question. Here is a copyright notice that we provide for the American Medical Association. Your continued participation in this webinar infers that you agree to the terms of this copyright notice. Should you not agree to acknowledge this copyright notice, you may disconnect now from this webinar. To fully understand rejections and denials, it really is important for you to recognize the path that a claim takes, or what we like to call the life of a claim. This is a simplified graphic, and it shows how a claim gets into our system. The provider or supplier, of course, is going to render a service. He or she will submit the claim, but the system might reject that claim or the batch of claims, and when this occurs, Medicare generates and sends a 277 or 999 report. This slide describes claim submission in a bit more detail. Most providers submit claims electronically. There are actually very few providers who qualify for a waiver under a law that prohibits Medicare from making payment on a claim when it is not submitted electronically. So most providers are submitting electronically. Now, to confirm claim receipt of an electronic claim, providers should use the 999 report, use the 277 report to get more specific information about your claim. Our electronic data interchange, or EDI staff, has created the Medicare 276-277 companion guide, and it is in this guide where you will find clarification, and you will see that we further define the data content requirement required for the electronic claim. Now, based on both of these reports, you'll know if the claim is rejected and if you need to correct or submit the claim or the batch of claims. This is a simplified graphic that shows what happens when Medicare deems a claim as unprocessable. These are called rejections. Of course, the service is provided, the claim is submitted, but something is wrong. It's invalid or incorrect. Something just doesn't make sense. It's in an incorrect format. Remittance advice is generated and sent then to the provider when a claim is rejected. This slide rather shows a side-by-side comparison of a claim rejection versus a claim denial, and these are really two very, very different things. Many people, us included, or WPS staff included, sometimes use these words interchangeably, and we really need to watch what we're saying. We can't use them interchangeably because they are so different. Left side of this slide, you'll see that a rejection is an unprocessable claim. We can't adjudicate the claim. It's returned on the front end, and the reason is that there's an incorrect format. Something's missing, something's invalid, or simply incorrect, as I mentioned. For these claims, because they're never adjusted, there are no appeal rights. What you need to do is resubmit the service. So you're going to need to fix it and resubmit it. Now, when the remittance advice is generated for rejected claims, you will see an MA130 and a CO16. I'm going to talk about those codes a little bit later on in the presentation. But if you see these codes on a remit, what it's going to tell you, or what it's going to mean, is that you need to fix and resubmit that claim. It is unprocessable. For these rejected claims, patients are not liable. You need to fix and resubmit the claim, and then liability will be determined later. A denial, on the other hand, is a claim that we have adjudicated. There is a denial could be for many reasons, including denials based on law, or what we call statutory requirements. Medical necessity, which includes frequency denials or utilization denials, would be another example of when a claim fails to meet payment criteria and we need to reject the claim. Let me correct myself. I just said reject. I should have said denied. For a denied claim, you will see an MA01 code on that remittance notice. And what this code does is provide appeal rights. Now, for most claims, claim denials, claim line denials, with very few exceptions, and I'll talk about one a bit later on, there are appeal rights. Patient liability for denied services is determined based on the reason for the denial and whether or not you presented your patient with that advance notice, that advanced beneficiary notice of non-covered, or the ABN. So this graphic then shows the path or the life of a claim when it's processed. The service is provided, the claim is submitted to Medicare, and based on edits and audits and processing, computer logic, the claim, sometimes it's a manual review, of course, the claim is either paid or denied, and then that remittance advice is generated. Let's talk about that remittance advice. It's very, very important. Sometimes we call it the remittance notice. You might hear it referred to as the RA, and some people even refer to it as the remit. Most providers will receive an electronic remittance advice, or an ERA, as opposed to a standard paper remittance, SPR. The ERA is going to include details about the transfer of funds and payment processing from the payer, in this case WPS, to the healthcare provider's bank. Depending on how the claim processed, it may include information about any adjustments made to the claim. It'll include information about denials. It could also include information about something that is missing. Sometimes it provides notice about refunds and offsets. Codes on the remittance advice provide information about the claim. I mentioned to you some codes earlier on when we had that side-by-side comparison of an an unprocessable claim or rejected claim versus a denied claim. So claim adjustment reason codes, or CARCs, explain why a claim paid differently than it was billed. Those CARCs, or claim adjustment reason codes, will appear on that remittance advice. Remittance advice remark codes, or RARCs, we call these RARCs sometimes, provide more details about an adjustment that's described by a claim adjustment reason code. So they provide further details. Another type of code that appears on the RA is a group code, and I mentioned one earlier, that's CO16, that appears on rejected claims. Group codes convey financial responsibility for the unpaid portion of the claim balance. So if you see a CO, it stands for contractual obligation. That means the provider is liable. If you see a PR on the remittance advice, that group code means that the patient is financially responsible. You can find code lists for RARCs and CARCs on the Washington Publishing Company website. You'll also see code lists for the group codes. Washington Publishing Company, or I'm going to call them WPC for short, actually maintains these codes for CMS. You can find the code lists on their website. I've included a link to the code lists and a link to their website here on this slide. It's embedded in your handout. I do want to mention to you that WPS understands that some of the codes may be rather cryptic. Some of them may seem to be a little out of date, perhaps because an outdated acronym is being used. We can't change this. We don't maintain those codes. It is the Washington Publishing Company, or WPC, that does that. On their website, if you're looking at the homepage on their website, there's actually contact information if you wish to contact them to suggest that they change one of their reason codes or something in those reason codes. I hosted a webinar a while back, and while I mentioned this to everyone that sometimes the information is outdated, in the survey comments, that brief survey that we ask you to fill out at the end of the presentation, the learner actually said that I was using outdated information in my presentation. I want you to know that I did so on purpose, because I want those reason codes that I'm going to talk about now to reflect the same reason codes that you see on your remittance advice. I know and I understand that the acronyms may be outdated, but I am providing you with the information that will print out on the remittance advice. So after reviewing that remittance advice, you're going to need to choose the action that you need to take to either fix or correct or resubmit, or even request an appeal if a claim denies. Of course, you fix and correct unprocessable claims. Some denials can be fixed, but denials would need that appeal request if you believe you should have been paid for something that Medicare did not allow payment for. So for an unprocessable or rejected claim, you're going to need to fix the error, resubmit the claim to Medicare. If the claim or claim line denied, there could be multiple actions to choose from. You may be able to simply resubmit the service. I've mentioned this a couple of times. You might also use the clerical error reopening, or CER process, to correct clerical errors. And CMS defines clerical errors, including minor errors or omissions, as human or mechanical errors on the part of the provider or the contractor. And I'll talk more about this process in just a couple of minutes. But another action to consider is an appeal. The remittance advice is going to provide appeal rights with few exceptions. I'll talk about that, one of those exceptions, later in this webinar. Now, registered users of our secure portal or transactional portal, it's that side of our website or part of our website that's secure. You need to log in when you use it. You can use that transactional portal to render a clerical error reopening yourself, or to request an appeal. And these self-service tools, these are just a couple of self-service tools that Medicare and CMS makes available, really do offer the most efficiencies. You're going to save time and save money by using them. Our portal user manual provides illustrations and step-by-step instructions on how to use these portal features as well as the other functionalities. Here's just a couple of CMS resources about the remittance advice if you'd like to learn more about it. Next, I want to talk about when you need to correct or appeal the MAC's decision to pay or deny a claim. For those of you that are unfamiliar with that acronym, MAC, it stands for Medicare Administrative Contractor. WPS is the Medicare Part A and B Medicare Administrative Contractor for Jurisdiction 5, which are the states of Iowa, Kansas, Missouri, and Nebraska, as well as those national Part A providers that were with us before transition over from a carrier to a MAC. And we are also the MAC for Part A and B in Indiana and Michigan. I talked earlier about the clerical error reopening process, that SIR process, and told you that I'd share some more details in a couple of minutes. This is the process to correct those human or mechanical errors. Clerical errors or minor errors are limited to those errors in form and content. They are not omissions, such as when you've failed a bill for a certain item or service. Your handout includes the link to a very helpful resource titled How to Request a Clerical Error Reopening. This is a resource on our website. It includes information about this SIR process. It provides examples of acceptable clerical error submissions. To give you some examples, mathematical or computational mistakes, transposed procedure or diagnostic codes, misapplication of a fee schedule, and there are more. There are also on that list or in that resource a list of situations that cannot be processed as a clerical error reopening. This includes comprehensive error rate testing issues, any provider enrollment issues, wrong payee situations, and some of those complex claim situations, such as when you bill for a not otherwise classified or NOC code, or claims with those modifiers that require documentation, such as the 22 modifier. Another thing or another reason that you cannot use the clerical error reopening process is claims that require any analysis of documentation. So not just those modifiers that require documentation, but any documentation analysis at all. This would not be a situation where you would use this. Remember, you can use our transactional portal for self-service for this process. Or you can request a clerical error reopening via telephone or fax. Remember that provider user manual provides instructions. There are 5 levels of appeal that would be provided for those claims that are claim lines that deny. You need to recognize that Medicare MACs, or Medicare Administrative Contractors rather, render only that level 1 determination. There are time limits that for submitting and for completing an appeal. There's also some monetary thresholds. We refer to these as the amount in controversy, or AIC. These monetary thresholds that apply to appeals apply only to level 3 and 5 of appeals. Based on a law, these monetary amounts, or the AIC, can change from year to year. Most often it does, sometimes it doesn't. You can check out a resource on our website, and I've actually loaded it to the next page. Actually, it's embedded there in your handout, of course. We have information on our website that provides details about who can request an appeal. The beneficiary or their representative may request an appeal for any service that's processed for them if it's an assigned claim. Providers and suppliers can appeal services on which they accepted assignment. So for unassigned claims, providers and suppliers can act as the beneficiary's representative, but the beneficiary for those non-assigned claims has to sign an authorization statement. However, Medicare does allow a provider or supplier to request a redetermination on an unassigned claim if Medicare denied that service is not reasonable and necessary, or in those cases where the provider billed in excess of the limiting charge. And of course, anytime a provider bills in excess of the limited charge, the provider would need to refund any fees collected from the beneficiary. On the right side of this page, and I know it might appear quite small here in this slide, but you have the link to it over on the left. One of my very favorite resources for appeals is the CMS fee-for-service appeals process flowchart. This flowchart is updated annually. If you look closely at the bottom of that graphic on the right side that shows that flow chart that's available on the website, you're going to see the date. This says the chart reflects the amounts for calendar year 2024. So if you begin looking at this or using it within your office, make certain you're aware that come 2024, this may change. The information on it may change. But if you look at this particular appeals flow chart, I mentioned to you that there are 5 levels of appeal. You can see them here. When you're looking at this flow chart, you will see that it includes both the standard and expedited processes for appeals. The standard process is for parts A and B, and the expedited appeals process applies for some Part A only appeals. Standard process on your left, expedited process on the right. So you can see the 5 levels. You can see the redetermination. You can see the qualified independent contractor reconsideration. The 3rd level of appeals is Office of Medicare Hearings and Appeals. It's an ALJ hearing, which is administrative law judge. And then the 5th and final, or the 4th level rather, I should say, is the Medicare Appeals Council. And the 5th and final level of an appeal is Federal District Court. I like this flow chart because it shows you the time limit you have to file. Oh, I went too far here. That didn't work. The time limit you have to file to the level of appeal, and it also tells you the time limit that the contractor has to make that decision on that appeal request. So 120 days to file a redetermination, for example, and the MAC has 60 days to render their decision. So this provides those time limits. You can see here under Office of Medicare Hearings and Appeals, there's an AIC equal to or greater than $180. And then the 5th level AIC is equal to or greater than $1,840. There's asterisks there, and if you look at the key at the bottom of the flow chart, you'll see that the AIC is adjusted annually. So again, pay attention to that calendar year date that you see on this really great CMS tool. All right, the next portion of this presentation includes a discussion of the data that I use to provide the most common rejections and denials for Specialty 16 Obstetrics and Gynecology. This webinar, as advertised, really focuses only on the data. We are not going to delve into policy, what's covered, what's not covered. We're talking today only about the common denials and rejections and how we can fix them or appeal them. So the data that I'm sharing is for all Specialty 16 submitted claims for Jurisdiction 5 and Jurisdiction 8. So this means all Obstetrics, Gynecology, Medicare claims submitted for Iowa, Kansas, Missouri, Nebraska, Indiana, and Michigan. While the dashboard does allow us to drill down by a specific state, I pulled data for both of our jurisdictions to present to you during this presentation. For those of you that are wondering what Specialty 16 is, Medicare assigns a 2-digit code to providers when they enroll. And during enrollment, the providers will actually self-designate their specialties. So we assign the 2-digit specialty code when the provider enrolls in Medicare. While they can designate a secondary specialty, I'm talking about MDs and DOs, it is the only it let me back up a minute. It is only the primary specialty, the one designated by the applicant, that is used during initial claim processing. So once they receive their Medicare number and they bill claims, the computer uses only that primary specialty when processing claims. Now, there are some situations where a provider will request an appeal, and they will stipulate or provide to us in that appeal request their secondary specialty. And sometimes Medicare can make payment then based on that secondary specialty. But it is only the initial or the primary specialty rather that's used during initial processing. That's why sometimes you need to request an appeal and tell Medicare you have that secondary specialty. Now, I pulled data for claim submission dates April 1 through June 30 of this year. The data was last refreshed on July 12 of 2024. Well, you might be asking, what does that mean? Well, the data was last refreshed on July 12. This means that any claims submitted for this date range, April through June, that were submitted after July 12 of 2024 will not be included, or that data is not included in the presentation that I'm going to give you now, the presentation of the data. So here are, based on that data poll that I did in analyzing that data, the common rejections for specialty 16 claims. The first common rejection you see on this slide is one that appears often on the remittance notice. That's why you'll see, typically a larger number of them. Remember that more than one reason code can print out on a claim. But whenever a claim is rejected, typically you're going to see that reason. Claim lacks information needed for adjudication. And in that case, you're going to need to look to those additional codes to really kind of zoom in on what it is that was missing. Those numbers you see out to the right side represent the number of rejections for that time period, for that data that I pulled. So then the next most common rejection reason for your specialty, if you're a specialty 16 provider, gynecology and obstetrics, is missing, incomplete, or invalid ordering primary identifier. That means just what it says. You're missing or that primary ordering provider number on your claim. Maybe it's incomplete. You didn't key it correctly. Maybe it's invalid. Maybe because it was keyed wrong, it doesn't match up to the clinic number on that claim. So missing, incomplete, invalid ordering primary identifier, big one for your specialty. Now the next two, take a look at that, folks, and look to the top of your claim. These are common rejections by reason. And earlier I told you it's important to keep these two separate. A rejection and a denial is a very different thing. But look at the first word in bullet 3 and 4. It says denied. I don't know why these reason codes print out the way they do. It says denied, but please be assured I'm talking about rejections. Invalid or missing modifier. Means exactly what it means. Now remember, I told you rejected claims you have to fix and resubmit. So you're going to need to look at the modifier or the fact that the modifier is missing. We have modifier fact sheets on our website that explains the use of nearly all the modifiers that exist. I'll point those out to you when I talk about the resources a little bit later on. Look at the next one, denied, and we're talking rejections here, rendering physician number invalid, missing. Well, 541 claims rejected or claim lines rejected because there was a missing or invalid, incomplete ordering primary identifier. In this case, it's the rendering provider number that's invalid or missing. So take a look at that. Make certain you keyed it correctly if you had it on the claim at all. If not, make certain the correct physician number is on there. Rendering physician is identified correctly on your claim, and submit a new claim. The next one is the facility and laboratory name and address. or PIN is missing. Now, certain information is required on a claim for lab services. I'll point out those resources to you in a little bit. But if the lab name or the address or the PIN is missing, it is unprocessable. You need to fix it, resubmit it. Now, CMS in their Internet-only manual, publication 100-04, Chapter 26, provides the claim processing requirements. Let me just pull that up here, cms.gov. And remember, these links are embedded. So I'm just, showing you or demonstrating some things throughout the program today that you'll be able to come back to later, because all of these resources are included in your presentation material. Here's CMS's homepage. If you want to find the internet-only manuals, scroll down the page and choose Manuals, Forms, and Transmittals. Next, you can choose to view internet-only manuals, and here they are all listed, all of the CMS manuals. I mentioned to you that claim form processing guidelines are in 100-04, Chapter 26. And remember, these are paper claim form instructions. So here is completing and processing the form CMS 1450 dataset. 26. I clicked on 25. That's part A. Here's chapter 26. This webinar today is for part B billers. So this is the paper claim form instructions, and you can see it goes item by item, what you need to place on the claim. Item 1, put this. Item 9, enter this, and so on and so forth. Now, probably some of you are saying, but I don't submit claims on paper. Well, our EDI staff, as I mentioned to you, has published a crosswalk that will take you from the paper, if it goes in item 1 on the paper claim form, where does it go on the electronic claim form, and what information do you need to put on that electronic claim form? So this crosswalks from a paper claim to an electronic claim. Very, very helpful. I've showed this tool to a lot of providers that didn't know it existed. One of the things I want to point out to you here is that this status code column shows an R, and sometimes it shows an S. Well, what does that mean? It tells you right here. An R means that the data element is needed in order to process the claim. If it's not there, it's unprocessable. It's rejected. An S in that status column means that the data element must be completed, but only if other conditions exist. So this is a situational status for that particular item. So a great tool that will be helpful for you to help avoid those unprocessable or rejected claims. Here are the other common rejections: missing, incomplete, invalid billing provider identifier 116. So look for that billing provider number. Is it incomplete? Is it missing? Fix it, resubmit it. Next one, claim must be submitted to Railroad Retirement Board. That's what RRB stands for. And claims for beneficiaries who have Medicare that retired from the railroad, their claims must be submitted to the railroad contractor, and that is Palmetto. So if you submit to WPS, we're going to reject that claim. In this case, there were 99 rejections because the claim was submitted to us when it should have went to Palmetto. Take a look at the next one: missing, incomplete, invalid name, strength, or dosage of drug. This is a tip to you that you billed for a drug on that claim, but we don't know what drug it is, or we don't know the strength or the dosage that may be required in order to process that claim. So my suggestion for this would be to take a look at that particular code that was billed and see if there's a policy that it pertains to. Let me go back here. I want to show you a tool on our website you can use to determine if a particular code appears in one of our local coverage determinations, or LCDs, or a national coverage determination. All of those are housed on the CMS website in their Medicare coverage database. And remember, all of these resources are in your handout. Here is the code lookup tool on our website. So if you, for example, want to know if let me just see here, 0585 appears in a local coverage determination or article, you can do a search on our website and look. There's a match. There's an LCD that governs this code, and there's a billing and coding article that includes this code. So if you have that line denied because there's missing, incomplete, invalid strength or dosage of a drug, you would need to look at the guidelines for that drug to see what it is that you need to report, and you would look at the claim form instructions to see where you need to report it. Claim denied because information received was this should say incomplete. There's a typo there. I apologize for that. That means the information that we received wasn't complete. We don't have enough information to process that claim. Take a look at that claim. Look what's missing, what it is that's required, and determine what you need to report and resubmit. Finally, the last of the common rejections that I analyzed for today's webinar is that the CLIA number is invalid or missing. Here's an acronym. It says denied, but it's rejected. CLIA stands for Clinical Laboratory Improvement Act, and this is a law, and this law requires numbers to be recorded on claims for any laboratory performing a CLIA covered procedure. And I've included the resource for CLIA procedures in your handout. But this law requires you need to get certification when you're doing labs within your office, and you need to report that number on your claim whenever you bill for those services. So there's a 10-digit CLIA certification number. It must be placed in item 23 of the CMS 1500 claim form or the electronic equivalent. And you can only bill one unique CLIA number per claim. So we talked about the reasons for rejections. What are the codes most commonly rejected? They're here for you. These are the common rejections by code. The G0101 is the top reasons for denial is, of course, that claim lacks information needed for adjudication, but this one's being denied for invalid or missing modifier, or the claim needs to be submitted to the railroad board. This is the cervical or vaginal cancer screening, pelvic, and clinical breast examination. Number one reason why we're rejecting that code is that it's invalid or missing modifier reported. G0444 is that annual depression screening. This is denying because no charges were submitted. So 0 charges were submitted for the dollar amount. And it's also being rejected because the claim has been forwarded to Palmetto Railroad Board. And in this case, sometimes the other insurer, if the beneficiary has insurance other than or in addition to Medicare, there may be a trading partner agreement they enter into, and that trading partner will say, we'll pay you, WPS Medicare, X dollars, or WPS Health Solutions, I should say, so many dollars per claim or so much money per claim, I don't know what it is, to automatically cross over that information to the other insurer, to us. So in that case, sometimes we will forward the claim information to the railroad board contractor for you. It depends on that trading partner agreement. 99213, just similar to the 99214 being denied because the rendering physician number is invalid or missing, or the billing provider's primary identifier is incorrect. The 76830 is a non-obstetrical transvaginal ultrasound. Missing, incomplete, invalid billing provider identifier. So you can see it really often doesn't have to do with the medical necessity of a service itself. It's just that something was missing from the claim and we have to reject it. 810002, of course, that's a lab. CLIA number invalid or missing. Invalid or missing modifier. Okay. The digital breast tomosynthesis bilateral. Being denied, invalid ordering primary identifier, invalid billing provider identifier, and the facility is not certified for digital mammograms. Another reason Medicare may reject the claim. 99214, of course, was similar to the 213. Q0091, this is being denied most often because field 11 of the claim form must be completed and it wasn't. Field 11 is that field on a claim that asks, is there another insurance primary to Medicare? You can't leave it blank. If it's blank, the claim is going to reject. You have to enter something there. We recommend that you enter none if there is no other primary insurer to Medicare. The 77067, I kind of skipped over that, but that's being rejected because the facility name or the lab name and address is missing. So the facility name is not there, and also because that facility is not certified for digital mammograms. The J0585 being rejected, invalid, missing modifier, or the claim lacks information needed for adjudication. And this, folks, is that Botox that I pulled up a bit ago. It's a Botox drug being administered. We do have that local coverage determination and article that tells you what is needed on the claim form. So I talked about rejections. Now I'm going to talk about denials. The common denial reasons are here. You can see procedure code submitted as a non-covered Medicare service. You can look to the physician fee schedule relative value file, and I'll have Leanne place that into the chat for you. In this relative value file, there's a status code column, and you can tell by looking at that status code column if that procedure code is one that is non-covered by Medicare. There is a key to reading that data file that you'll need to use to see what status codes mean what it means, each of those status codes. So if it's an N, it's a non-covered service. So for example, what you'll want to do is not bill the patient for that. For a non-covered service, you really don't even have to submit the claim. Let's take a look at the next two common denials, and this is similar to every other specialty out there, folks. We receive and deny claims every single day for duplicates. Could be a duplicate charge. Maybe it's a duplicate charge we already paid on another day, on another claim ICN. That's what that second one stands for. Look at the numbers. 1,200 or 1,341, 1,323. That's a lot of claims, and that means a lot of money spent needlessly, both by the provider and by Medicare. The provider, of course, to prepare and submit the claim, Medicare to process the claim, only to deny it. Duplicate charge. We have a resource on our website that speaks to duplicate charges. We really want to lower the number of duplicate denials. That resource that I gave you that talks about claim denials and categorizes different kinds of claim denials like bundling and non-covered or excuse me, duplicate and so on and so forth. You know, it costs a lot of money for both you and Medicare. So we address what you can do to prevent some of those duplicate denials. The one thing is to check to see if you automatically resubmit on a cycle. You know, you should be waiting at least 45 days to ever consider resubmitting a claim if you haven't received our notice on it. Remember, we have payment floors. We have to wait a certain amount of time before we can release payment. If you pay a billing service to resubmit a claim every 30 days because you haven't received a remit with that on, that is considered abuse, or it may be considered abuse, repetitive submission of duplicate claims. So if you or a billing service is doing that, we recommend that you stop doing so. Next common denial, Medicare pays only one screening pap smear every 2 years, 1,200. We know that there's a frequency parameter for screening paps once every 2 years. If it's billed more than that, it's going to be denied. So you want to take a look at those self-service tools that will show you the last date these were indeed billed. Medicare does not pay for this service or item. 743 means it's a non-covered service. Again, that Medicare relative value file will show you status code or status for each codes. This physician is not eligible to receive payments. 372 denials. Maybe you transposed something when you reported the physician ID on the claim. Maybe you didn't. Maybe that physician is indeed or physician or provider isn't eligible to receive Medicare payment. That would be like a provider enrollment issue that you would want to check into. Claim must be sent to EGHP first. EGHP stands for Employer Group Health Plan. That, folks, is a Medicare secondary payer situation where the claim has to be processed first by the primary insurer to Medicare. We have, and I've included resources for you all about Medicare secondary payer. We have some great videos out on our YouTube channel. We have a lot of education that will help you avoid these denials. Of course, you're going to need to check eligibility to determine where to submit that claim. Ask your patients every time they come in, did something change? Do you have a new insurance card? And so on and so forth. Ways to avoid these common denials. Separate payment not made for this service, do not bill patient. That's a bundling type denial. And we do have a resource on our website. I have the link embedded in your handout, but it is this resource, Common Claim Denials. This is one I touched on a little bit earlier. Here is where we use reason codes and remark codes that will appear on your remit and provide for you actions that you can take to avoid or fix these particular common claim denials. We have a similar resource for rejections also. I didn't show you that one, but we have bundled services. We have the National Correct Coding Initiative edit information, which of course will help you with bundling. Global surgery rules, you know how to avoid those, how to fix them. Here's that duplicate claim information, our service information. I told you that we have the resource for. We have, you know, ways to avoid those denials. Entitlement denials, you know, expenses incurred prior to coverage. We have payer or contractor denials. Like if the claim isn't covered by us, you need to send it to someone else. If your patient has Medicare Advantage, it needs to go to Medicare Advantage, not to WPS. And then we have some hospice denials, and then we have provider number denials. You'll know that those were a heavy duty reason for claim denials for your specialty. So a great resource for you. Procedure must be billed with the primary service. Take a look at your code and see whether or not it's an add-on service or one that requires that you bill it in addition to a primary code. I'm so sorry. I scrolled inadvertently. Oh, I went too far. Payment included in another service. That's those bundling type services. You'd want to consult the National Correct Coding Initiative edits to avoid those. And I just showed you where you find the information to avoid those. But you will need to use those that tool, or you could use that physician fee schedule relative value file. Leanne put the URL or the link for that into the chat because I did not include that, unfortunately, in the resources. All right, here are then the most commonly denied CPT and HCPCS codes for your specialty 16. Hitting the list again, that G0101, Medicare can only pay the screening PEP every 2 years. That's why this claim is denying its frequency. We're also denying this code because the beneficiary is a Medicare Advantage patient. We can't process claims if the patient is elected a Part C plan, a Medicare Advantage plan. And we're also denying this code because it's dupe. It's a duplicate. 99397 procedure code is a non-covered service. Medicare does not pay for this item or service, so you don't even need to submit it to Medicare, but that's why we're denying that code. Over 1,800 claims in 3 months. The next one, the 99213, the number one reason we're denying that office visit, duplicate. The second reason is that it's a managed care beneficiary. They have Medicare Advantage, not traditional or original Medicare. Physician or supplier not eligible to receive payment is the other reason. The Q0091, we're denying this due to frequency. This, of course, is that obtaining, preparing, and conveyance of a PAP to a lab. Second, we deny it because it's a duplicate. And third, because it's not medically necessary. Which of course, if we don't pay for the PAP, we're not going to pay for the obtaining, preparing, and conveyance. 99459, this is a procedure that has to be billed with a primary service. This is the pelvic exam practice expense code. So it needs to be billed with a primary service or we'll deny it. Another reason this is denying is because the physician is not eligible to receive payment, and we're also denying for dupes. 99214, number one reason for denial, duplicate. Number two, your patient is a managed care patient, a Medicare Advantage patient. And number three, not eligible to receive payment. And I threw a number four in for this one because this code, the 99214, office visit, is being denied by Medicare because it is pre or post-op care that is included in surgery, and that, folks, to avoid that, you'd need to look at the global billing for that particular the global surgery billing guidelines to avoid that. 99396, preventive E&M, established visit between 40 and 64 years of age. Non-covered service. Most of our beneficiaries are 65. This is a non-covered service. Medicare doesn't pay for this item or service, and the physician or supplier that is not eligible to receive payment are the other reasons we're denying that. The 99204, number one reason we're denying, we can pay only one initial visit per specialty. So this means that someone else with specialty 16 also billed an initial visit. We can only pay one initial visit per specialty. Those are E&M guidelines. You would look in CMS's evaluation and management guidebook for that information. And WPS has just done, a plethora of events about evaluation and management services, and we speak often in those we did speak often, or it's still there out in a recording on our YouTube channel, about the fact that you can bill only one initial visit per specialty every 3 years. 81002, number one reason for denial is that the provider didn't enroll in the CLIA program. They don't have the certification number to put on the claim so that we can pay that lab. Number two is dupe. Number three is that the provider number is not valid for these services. And finally, 99203, number one reason for denials is the patient is a Medicare Advantage beneficiary. Another reason we reject this is only one initial, or reject, you caught me, we deny this, is only one initial visit per specialty, or the physician or supplier is not eligible. So a lot of these rejections and denials that I talked about are really fairly simple fixes, those that are the most common, and we can save a ton of money, the Medicare Trust Fund and you within your offices and organizations, if we can really focus on fixing some of these reasons for adjustments and denials. I mentioned to you earlier that we can further break down our data. We can actually break down as far as county if someone wants. We can also look at trending, and here's an example of trending. We looked at a denial. The time limit for filing your claim is expired, no appeal right. That, folks, is one of those exceptions I talked about earlier where there is no appeal right. This data that we look at, and all of this data that I pulled, you literally put in what you want to see, and within seconds or a second, all of this data comes back. It's remarkable. When I look at J5 and J8, or Jurisdiction 5 and Jurisdiction 8 claims, all specialties, which are thousands and thousands of claims, boom, those reasons come back just like that because we have this database, the dashboard built, our data informatics team, we call them Insight, has actually prepared these dashboards. I can go in and say, I want to see all specialty 16 providers in Iowa in such and such a county for this, look at this date range or that date range. I can even drill down to a code. But this trending, I'm getting off the topic here, 3 months, claim count, current 3 months, 179. 3 months prior was only 52, so the difference in the number of claims for these 3 months is 127. So the change is up 244%. This is the kind of data that we use to determine what we need to provide education on. And it's also a pretty darn good reason for me to show you where you can find information on our website to avoid that timely filing denial. And I'm just going to do a quick search here. Timely filing of claims. Tells you right here the patient responsibilities when claims are denied. You can only charge up to 20% of what Medicare would have allowed had we paid the claim. This tells you that claims denied for timely filing don't have appeal rights. This addresses those situations where providers ask us to reopen a claim that's denied for timely filing because another insurance recouped their previous payment, and that's what caused the delay. This tells you the internet-only manual citation. It's right here. This is what CMS says about when that happens. If the information provided was wrong, this other insurance comes back and recoups money. CMS says that that does not constitute good cause for the purpose of reopening that claim, and that's why we don't pay it. Now, if you think you have a reason that can extend that filing limit, you can file a waiver to extend it, and right here is the information you need. Of course, you would need to choose the correct jurisdiction to get these addresses down here. I'm on J8. If you look at J5, you'll see it switches over to Iowa, Kansas, Missouri, Nebraska. But that, folks, is the information about timely filing. And the fact that this went up 244% for your specialty in 3 months is why I'm talking about it today. Resources and tools. Here's that internet-only manual publication, the crosswalk. I showed these to you. Here's that great article on our website that lists by remark codes how to fix rejected claims. I showed you this one. This is the common claim denials. There's categories of denials here. One is global surgery. I talked just a little about that. Our website, we have MSP questions and answers that will help you with those MSP denials. Here is the live events webpage and our Encore presentations webpage. The link to our YouTube channel, I've included for you a direct link that will take you to a video about Medicare Advantage plans and how to determine your patient has MA instead of Medicare. There is a preventive service playlist. A lot of the rejections and denials I talked about today were preventive services, so I wanted to provide you with this resource. We actually have a playlist with several recordings of preventive services type education. Modifiers had a couple of rejections, I believe, for invalid, incorrect modifiers. Our modifier webpage on our website, I'm just going to do it the quickest way here and search for modifiers. Our modifiers webpage, and you have the link to it, includes all of these modifier fact sheets. Okay. So great information. The modifier fact sheets will often say these are appropriate uses, these are inappropriate uses, these are the codes you can use this modifier on, and so on and so forth. Some great information for you. Timely filing of claims is a link to that web page that I just showed you. I've included this "we want to partner with you" because I know that some of you belong to professional organizations and societies, and sometimes you want a WPS speaker to either come in person or to provide a presentation for you virtually. That's where you get to information to request a speaker. Freedom of Information Act is if you work in an organization and you want to know what are our clinic ABCs, what are our top rejections and denials, you can request that through the Freedom of Information. This tells you about the Freedom of Information Act and that charges may apply for providing that information. Provider enrollment guides and resources. This will help assist you in keeping your record up to date or applying for a provider number. E&M services guide, I talked about that. That's where you'll find information about only one initial E&M service within a 3-year period per specialty. Correct coding initiative edits. A lot of the rejections or denials today had to do with the ordering provider. A referring provider, not there. There's a data set out on the CMS website that gives you a list of all eligible ordering and referring providers, and it includes their identifiers. That's how you can get the correct identifier onto your claim. Here's a great publication CMS has made, checking Medicare eligibility, and I think I fibbed a little. I told you that I didn't put the relative value file link on your resources, but I did. But thanks anyway to Leanne for placing that into the chat. Here is an interactive link to an interactive map on CMS's website. You can click on Michigan, you can click on Iowa, you can click on Hawaii. You can see all of the contractors for that state. All of the medical review contractors. You can see who the RAC is, the Recovery Audit Contractor. You can see who the MAC is. You can see um, just a ton of great information out there. It helps you determine who you need to send your claim to. Where is it? It'll provide the railroad board contractor contact information, for example. That's why that's there. CLIA, all things CLIA are on the CLIA webpage, talks about getting that certification number and reporting it. CMS has some great preventive service tools on their website, just a ton of them. I love the they have one that just will show you of those all of the offerings that CMS allows Medicare to make payment on, those preventive services. If you click on, PAP screen, it brings up information specific to PAP screen, and it provides you with some great tips and tools. So I highly recommend you take a look at that. I'll just go there. I know I'm just running just a little over. This is what I was talking about there, those preventive services. This is the website. There's actually out there an interactive list of the services that you can take a look at back here. Just a really great resource. We have information or a link here to the Beneficiary Notice Initiative. I know I mentioned medical necessity a couple of times today. If you believe the likelihood that Medicare will deny your claim is not medically necessary, you need to know about the Beneficiary Notice Initiative, and you need to consider presenting your patient with that ABN in advance of the service. Medicare Coverage Database has all of the local coverage determinations and articles and national articles, as well as those that are proposed. This Welcome to the MCD search and how to use it is going to help you get into that database, move around, and more efficiently find the information you're looking for. The IVR is a self-service tool. We do offer a guide in using it. This will help you with claim status and details. Here is information about that secure portal that I mentioned today. Both of these are available 24 hours a day, 7 days a week, but they do have limited functionality outside normal business hours. And instructions for using that secure portal are in our portal user manual. If you look at our website, we have a link on every single page. Really easy to find. If you're on the WPS web page, any web page you want, you can click anywhere you want. And you'll always look and find that portal user manual link right here below the login for using that secure site. All right. Well, folks, this takes us to time for questions and answers. And one of the things that I had asked Leanne to do, and I want to come back to because I think it's really important, is that today's webinar focuses, just as I advertised, on rejections and denials. We didn't get into coverage and payment and policy for OBGYN services, and that's by design because one of my colleagues just offered that education in July. There are 2 encore presentations in our on our YouTube channel. One is called OBGYN Evaluation and Management and Preventive Services. The other was OBGYN Delivery and Surgical Services. Those delve into coverage criteria for your specialty claims. Provides a bit of information that's included in policy. So if you're looking for that information, because today's webinar is designed to talk about the data, the rejections and denials, go out to the YouTube channel and take a look at that. And actually, these 2 encore presentations should still be available on our website on our encore presentations webpage. And you have a link to that on one of your slides. I think it's slide 36 or thereabout. So if you're looking for coverage, LCD information, things that I didn't advertise I would talk about today, you can look there. I'll tell you in just a minute how you can send any unanswered questions to me or questions you think of. Anything you've already put into the chat, I will look at following this event. I do apologize for running over, folks. Our greatest compliment is when you recommend our education to others. Please feel free to share this information with anyone in our jurisdiction. Our goal is to provide the current and effective education for all in our jurisdictions. So if you can help us get the word out, that is fantastic. On behalf of myself and Leanne Foster and the entire provider outreach and education team, I want to thank you for your participation. I look forward to your survey comments. and hope to have you join us for future events. You may now disconnect. Thanks, everyone.